Welcome to AIS Channel Open Classroom. Today we're bringing you a lecture by Dr. José Balibrea from Valdebron University Hospital, in which several aspects of the effects of bariatric surgery on non-alcoholic fatty liver disease will be discussed. Non-alcoholic fatty liver disease was first described in 1980 and is divided into the histological categories of non-alcoholic fatty liver, which includes patients with isolated hepatic steatosis and patients with steatosis and mild nonspecific inflammation, as well as non-alcoholic steatohepatitis, which is distinguished from the former by the additional presence of features of hepatocellular injury with or without fibrosis. Non-alcoholic steatohepatitis is considered to be the progressive subtype of NAFLD. However, data suggests that hepatic steatosis with inflammation has a distinct and more progressive natural history than isolated hepatic steatosis. Non-alcoholic fatty liver disease is currently the most common cause of chronic liver disease. In general terms, its overall prevalence varies between 20 and 50% in Western countries. Moreover, fatty liver is a condition very frequently linked to obesity, since it is found in 10 to 15% of normal weight individuals and in 70% of obese subjects. NAFLD has been recognized as a hepatic manifestation of metabolic syndrome linked to insulin resistance. Patients with NAFLD in general, and those with non-alcoholic steatohepatitis in particular, are at increased risk of mortality from liver disease, 13%, and more commonly from cardiovascular disease, 25%, and malignancy, 28%. Therefore, its clinical relevance relies on the fact that in Western countries it is the leading cause of hepatocellular carcinoma and will be the most important etiology for liver transplantation referral by 2020. When considering the presence of morbid obesity, many pathophysiological events should be taken into account. Most of them are related to the development of both hormonal and pro-inflammatory changes that are due not only to an excess of adipose tissue mass, but also to a change in its behavior. Similar to what happens with quorum-sensing signals in bacteria, when the amount of adipose tissue, especially visceral fat, reaches a point, several pro-inflammatory phenotypic changes are observed in the adipocytes, leading to the production of a number of signals that contribute to the development of the classic obesity-related comorbidities, such as type 2 diabetes, high blood pressure, dyslipidemia, sleep apnea, or arthrosis. Interestingly, despite its sharing several pathophysiological pathways and epiphenomena, fatty liver disease was not considered a true obesity-related comorbidity until a few years ago. Hence, why consider bariatric or metabolic surgery for treating fatty liver disease? Firstly, because morbid obesity and NAFLD-NASH are commonly associated, and bariatric surgery is the most effective treatment for MO. Moreover, this type of surgery has demonstrated that it offers not only an important improvement as regards survival, but also reverts most of the related comorbidities. Also, it modifies some of the pathophysiological phenomena observed in NASH, and can be considered a safe treatment and the most effective treatment for NAFLD-NASH to date that offers excellent results with benefits beyond weight loss. However, there are several concerns about the possibility of treating patients with a severe liver condition using bariatric surgery. Most of these concerns are due to the side effects of malabsorptive techniques that are based on historical reports with a 7 to 10% cirrhosis rate after jejunal allele bypass and the well-known long-term sequelae of biliopancreatic diversions. Moreover, an aggressive malabsorptive procedure can lead to deleterious effects such as more bowel bacterial overgrowth, severe malnutrition, and diminished drug absorption, especially of immunosuppressants. In addition, liver failure has also been typically considered a risk factor for postoperative complications, not only for bariatric, but also for almost every kind of digestive surgery procedure. The presence of cirrhosis plays a key role since its presence can generate significant technical difficulties due to the presence of both augmented collateral venous circulation and tissue edema. Therefore, a higher anastomotic lead rate has been observed due to mechanical issues, but also related to impaired cicatrization, edema, or microbiological changes. Hence, the presence of end-stage liver disease has been related with a twofold mortality rate and a 21-fold mortality rate if decompensation, i.e. severe ascites, is present. Finally, for most gastroenterologists, bariatric surgery is still considered a time-consuming, complicated, unsafe and expensive treatment. Weight loss surgery works not only by changing anatomy, but also by generating significant hormonal changes, decreased insulin resistance, improvement in the lipid profile, diminished systemic pro-inflammatory signals, and microbiome changes, among others. The vast majority of these effects could be beneficial also in NAFLD-NASH patients, since these procedures improve two key factors in the fatty liver disease pathophysiological pathways: inflammation and insulin resistance. If we compare the most commonly employed procedures, gastric bypass and sleeve gastrectomy, we can see that both of them offer restriction as the very first mechanism of action. Nevertheless, GBP generates a duodenal exclusion and a putative allele overload that result in augmented GLP-1 secretion. However, this increase in GLP-1 concentration has also been observed after SG, may be due to a faster gastric emptying. Moreover, during SG, the gastric fundus is removed and most ghrelin production is eliminated. Finally, other effects observed after SG, such as both vagus nerve and pylorus preservation, should be studied in depth in order to assess their possible influence on the neurohormonal changes after bariatric surgery. After bariatric surgery, several effects that can alter NAFLD-NASH pathogenesis occur. In most procedures, PYY, GLP-1, GLP-2, and adiponectin levels rise, leading to better insulin secretion and sensitivity and diminishing its resistance and glucose output, as well as an overall improvement in the obesity-related pro-inflammatory status that plays a key role in the development of both liver steatosis and fibrosis. Also, after bariatric surgery, an upregulation of the peroxisome proliferate reactivated receptor gamma, PPAR gamma or PPARG, also known as the glitazone receptor, is observed, leading to enhanced lipid exportation and beta oxidation and improves insulin sensitivity. Moreover, increased levels of YY peptide can diminish or even arrest fibrosis by diminishing the local expression of several related factors, such as metalloproteases, type Ia collagen, alpha-smooth muscle actin, or transforming growth factor beta. Finally, changes in the gut microbiome due to bariatric surgery increasing the Firmicutes proteobacteria ratio can also prevent the free fatty acids accumulation-related hepatocyte loss, improving not only lipid storage and energy expenditure, but also insulin sensitivity. To date, the beneficial effects of bariatric surgery on fatty liver disease have been assessed mainly by observational studies, in which clear laboratory data improvement has been observed, as well as a 75% decrease in the steatosis rate, a downstaging of the NAFLD score from 1.9 to 1, and a decreased fibrosis rate by about 65 to 70%, with a 65% NASH resolution rate. Also, it is thought that BS can stop the development of NASH in up to 50% of patients if it is performed during the first 5 years. Finally, it seems logical to think that BS itself is contributing to the diagnosis of both NASH and HCC in earlier stages. As mentioned before, reports in the literature about the effects of BS on fatty liver disease remain scarce and are based on data from observational studies. Very few were prospective, and none was designed or powered to assess the effectiveness of bariatric procedures on NAFLD or NASH. Hence, several reporting scores have been employed, and most results include series in which patients underwent a gastric bypass. Because information on bariatric surgery and NASH coming from prospective studies or randomized controlled trials remains scarce, it is very difficult to find both meta-analyses or systematic reviews that help to obtain strong conclusions. However, in the study published at the University of Texas Medical Branch, after meta-analysis, it was shown that the resolution rate was 82% for steatohepatitis and 66% for fibrosis. Many scientific societies are aware of the beneficial effects of BD on fatty liver disease and are publishing some recommendations in order to consider it a valid option for treating NAFLD or NASH. Hence, the American Gastroenterological Association considers that BS itself can be performed safely in patients with NAFLD-NASH, but without cirrhosis. Moreover, it is also said that it is premature to consider foregut surgery as an option to specifically treat fatty liver disease. Moreover, when Chavez Tapia and colleagues carried out and published a systematic review and meta-analysis following the Cochrane library requirements, they found that, among patients with severe obesity undergoing bariatric surgery, the prevalence of NAFLD can exceed 90%, and up to 5% of these patients may have unsuspected cirrhosis. Bariatric surgery can improve obesity-related diseases in addition to reducing body weight. As a result, it has more recently been termed metabolic surgery. No randomized controlled trials examining the effects of bariatric surgery on NAFLD were found in the literature search. Large-scale clinical studies are urgently needed to further evaluate the role of bariatric surgery as a viable option for the treatment of NAFLD and the obese population. Also, current guidelines for managing NAFLD-NASH by the European Societies for the Study of Liver Disease, Diabetes and Obesity state that weight loss surgery can stop NASH progression as well as improve all its histological features. From the point of view of the surgical societies, especially IFSO, end-stage liver failure and/or cirrhosis remain a major contraindication for bariatric surgery. Nevertheless, IFSO's current position statement about bariatric surgery indications considers that weight loss surgery is able to induce not only an improvement, but also resolution of NAFLD and NASH. Bariatric surgery for NAFLD and NASH could be a cost-effective strategy, at least from the theoretical point of view. Due to the lack of clinical trials, a recent study published by Dr. Lee Kaplan, among others, proposed a simulation model to evaluate it. Several clinical scenarios were generated considering fibrosis grade, the presence or absence of decompensation, and development of hepatocellular carcinoma. For every single combination surgery, lifestyle interventions and no treatment were proposed. The probability of death was estimated based on age, BMI, and fibrosis. The results revealed that bariatric surgery augmented both life expectancy and qualities in all patients, being clearly superior to lifestyle interventions and no treatment. Moreover, if bariatric surgery is performed, the number of patients to treat to prevent a death due to liver failure or cirrhosis development in both patients with obesity and overweight patients was very low, between 6 and 11, especially in those with a high-grade F3 fibrosis. On the cost-effectiveness acceptability of every different treatment in different types of overweight patients, depending on the fibrosis grade was assessed, clearly the best results were observed if gastric bypass was proposed. Furthermore, if the same consideration was made for obese patients, gastric bypass is the most cost-effective treatment, no matter what grade of fibrosis was present. Unfortunately, as indicated in the discussion section, RCTs assessing the true clinical value of bariatric surgery for fatty liver disease are currently unlikely to be developed in the near future due to expenses, difficulties recruiting patients, and stakeholder reservations. In conclusion, and as take-home messages, we can say that, first, it is clear that bariatric surgery can improve both the clinical and the histological parameters of NASH. The beneficial effects of this therapeutic strategy are also produced by other mechanisms other than weight loss. In fact, it can be considered a safe option with a probably favorable cost-benefit profile. Finally, it is very important to remember that all the available information is based only on observational studies, and therefore there is a clear need for large-scale clinical studies in order to evaluate the role of bariatric surgery as a viable option for the treatment of NAFLD in the obese population, and maybe consider it as an indication as happened with type 2 diabetes and metabolic surgery.